Hello friends, welcome to the World Laparoscopic Training Institute, Orlando, Florida. And this is my pleasure to discuss the sleeve gastrectomy here because already we have discussed about the metabolism of the morbid obesity, to whom you should perform, to whom not to perform, and how to select the patient and how to do the different type of surgery for different type of patients. So in this video, I am directly showing you how to perform sleeve gastrectomy. First, I will show you. There are two videos I am going to demonstrate you. In first video, I am going to demonstrate you how to do sleeve gastrectomy with the simple stapler, that is the Multifire stapler, and we will use purple cartridge. But in this video, we will see that how to do the ICG for testing the angle of his blood supply so that there should not be any leak. And another video I am going to demonstrate you little bit about the single fire stapler, in which it is a power stapler, and in one firing you can do entire sleeve gastrectomy with few minutes only, and it has a very smooth staple line, and with the one firing entire sleeve will be performed. So these are the two videos. So let us see. I am starting the video, and both the videos are back to back, so we will see how to perform.
Okay, yeah, there are two doctors coming.
Like hello.
Yes, we can start now, doctor. Uno, dos, uno, dos, tres, cuatro, cinco, seis, siete. Yes, sir.
How to perform the sleeve gastrectomy. So, sleeve gastrectomy is one of the very important surgery performed by the general surgeons and bariatric surgeon. So, this is the port position. Our target is the gastroesophageal junction, because that is the most crucial part where you have to take care. Maximum bleeding also can happen, and you should be careful about the making the dog ear and going away from the esophagus. So your optical port will be approximately 22 centimeter below the GP sternum if you are using 45 centimeter instrument. And in the bariatric, it is important that you should have the long instrument, like 45 centimeters should be the instrument length. And your trocar also should be 20 centimeters. So you can see that this is this is the adult instrument and this is a bariatric instrument. So bariatric instruments are quite long. This is 45 centimeter in the length, and this is longer one. And various needle also you should use 20 centimeter. So you can see this is the simple 12 centimeter and this is 20 centimeter various needle. And the trocar length also should be 20 centimeter. You cannot use simple 12 centimeter trocar, so 20 centimeter trocar, because of the obesity. So this is the optical port which you will put first, and then you have to put one right hypochondrium and one left hypochondrium port. These two will be your working port. The left one should be little high, left one should be little low, and right one should be little high, because your target is little towards the left. So that's why right should be little up, because in the baseball, your baseball should tilt little towards the left. So left will be up, right will be down. Your left, and your left is patient right. So right one will be up, left will be little down. And one epigastric port should be used for liver retractor. That is important. That is for the Nathanson liver retractor. And the one, this is the telescope. This is your left hand. This is your right hand. So these are the three basic ports and one epigastric for Nathanson lever retractor. After that, one should be for assistant to the anterior axillary line, that is for assistant to hold the short gastric, and one here should be for a stapler at the level of umbilicus for endogyneal stapler, and this should be 12 or 15 if you have a stapler diameter. Staplers are 12 also, 15 also. So mostly the Covidian is making 12 so this 12 stapler you will use here. So these are the 6 port. This is first, this is second, this is third, this is fourth, this one is fifth, and this is sixth. So these 6 port you will introduce Nathanson lever and then started the surgery. So first step is that all the momentum should be brought down, and you should look for the spleen, lift the lever and see the first and second gastric pedicle, check for the caudate lobe, check for the pars flaccida, check for the lesser curvature, and then you should introduce, this is the gallbladder. Here is the pylorus, which you can see white color, and vein of Mayo, you can see pre-pyloric vein of the Mayo, and this is the gallbladder, liver, and this is pylorus. So from here you have to calculate 6 centimeter, and this is the liver. So after diagnostic laparoscopy, you will put epigastric port and you will introduce the Nathanson lever retractor to retract the left lobe of the liver. So initially it will be 5 port. After that you will remove the cannula, and percutaneously we have to introduce the Nathanson lever retractor and lift the liver. So liver is lifted, and after that you will start lifting the stomach. There is a bougie, but that bougie should be pulled up, so that lifting the liver, and this is the measuring tape that we will use the breech of the mask which is used, sterilize it, and you can use it for measuring the 6 centimeter from pylorus, and then you can burn it little bit with the bipolar, so that you will remember that this is the 6 centimeter, and then this tape can be removed with the 5 port also. This is a bridge of the mask which we cut the mask and remove that plastic. After that you will lift the stomach just like a bread, and bougie will be pulled up, and first you will make the, at the level of body of the stomach you will lift it, and then you will make a retrogastric, a small tunnel. You should remain as near as possible to the stomach. Left hand is giving the anterior traction by holding the stomach with a atraumatic grasper. And we can see posterior wall of the stomach is visible. After that it will be easy, just you put one jaw of the grasper inside and another jaw up, and you have to separate all the short gastric up to the left crus. Once you will progress few centimeter, after that you can ask your assistant to lift the momentum so that further dissection will be easy. So assistant is helping you, and then you can further continue. The long 45 centimeter instrument is very useful here, so that you can reach easily to the fundus part of the stomach. Now once you reach near the spleen, you have to be little careful so that a spleen should not be injured, and any traction can avulge the parenchyma, so you should be gentle at this place. You should ask your assistant to hold this, all the momentum, and pull it down. And it is reaching up to the left crus. You should examine it. You should also see that there should not be any hiatus hernia, and for that it is always better to do endoscopy before. You should tell the patient to get, or you can do yourself, and then you should rule out any hiatus hernia. If hiatus hernia is, then it has to be repaired. So we can see we have reached little to the crus, and now little bit the peritoneum over the left crus is separated, and this is fine. There is no any hiatus hernia in this patient. You should also look for any posterior adhesion of the posterior abdominal wall, especially if the patient who has gastritis or alcoholic or a smoker, you can get some adhesion, so that also has to be separated. So this is done, and now you can go little towards the antrum, so that the marking which you have given at 6 centimeter, you have to reach up to there. This white marking you can see. You can use like a short harmonic, tripolar, thunderbeat, ensil, any instrument you can use. And this is done. Now the posterior wall of the stomach is examined for any adhesion, and everything looks fine. After that, you will put either a gastric calibration tube or you can use endoscope. And just tell the anesthetist to push this bougie towards the pylorus. And with the grasper, you will help him to guide the bougie towards the pylorus. So it has gone towards the pylorus. And after that, you will take the stapler. So either you can use purple color or you can use green color, the first cartridge. This is the endo-GI linear stapler. And this is to articulate. There is a knob to articulate. And this is to rotate. So this is roticulator. And there is a one button to activate firing. So it has two mode. One is grasper mode and another is stapler mode. And this is, you can see written push before firing. Once you started firing, then you can see surgeon is standing in between the leg. One assistant is right, one assistant is left. And you may stand, right side also. It is not necessary always to stand in between the leg. Many surgeons, they stand right. And this is, now the stapler is introduced. After that, you will open the cartridge and then you will negotiate it in such a way that one jaw should go inside, another jaw should go outside. And you have to be careful that the bougie should be there. You should be 3 centimeter away from the incisura angularis. From incisura angularis, because a stricture happen maximum in this area. And whenever you will do that, you have to hold it. And you should check by rotating the cartridge that posterior and anterior wall should be taken equal, so that there should not be any cork screw appearance. and then you will fire. So pre-firing, you have to wait for a couple of minutes so that the fluid will displace, and this is just rotating it to check that posterior wall is also equally taken. Anterior and posterior should be equally taken. Some people, they put the bougie after firing the first stapler. Sometime you every firing, also after every firing you can wait for few seconds, and that has an advantage that absolutely no bleeding will happen on the stapler margin. So it is reached. After that you can again wait for few seconds and you can pull the blade back, and it's done. You can see 3 row of a staple is applied either side and it is cut in between. Then you can load the another cartridge, either purple, or if you have the blue one you can use blue. We have to articulate it in the direction. Again, make it sure that anterior and posterior wall both should be taken equal and bougie should be present. Direction should be nicely articulating, and then again fire. So we can see your left hand has a stapler and right hand has a grasper to make it sure that anterior and posterior wall is equally taken. And then again, this is the second cartridge which is getting fired. After each firing, in each one firing, your blade will and move 15 mm. So after each firing, you can wait for few seconds and then fire second. That will achieve the better hemostasis, and it's done. Again, blade will be pulled back. Now another cartridge you will fire. You have to straighten before pulling the stapler. Now this is the third cartridge. Again you have to articulate in the direction. And then again just lock it. Right now it is in grasper mode. And wait. After that you can ask your assistant to just tell him to inject 2 ml of the ICG IV. By the time assistant is holding the stapler, and you will wait for your nurse to inject the ICG in any of the peripheral vein. And what is the advantage? That it will illuminate the blood supply of the angle of his, and you can easily locate that how to make a dog ear, and then you will not damage the blood supply of the angle of his, because maximum leak happen at that point, because it has a minimum blood supply. So that's why it is important. And nowadays ICG is used. We can see this is the ICG mode, and the blood vessels are getting green. You can see this is the contrast mode of the ICG, and we can see we are not damaging any blood vessel. So you should be at least 1 centimeter away from angle of his, that is gastroesophageal junction, 3 centimeter from incisura angularis, and 4 to 6 centimeter from the pylorus. And ICG is confirmed that we are at correct place, and no blood supply is compromised, and there will be making a dog ear. So it's reached. The length of the one cartridge is 6 centimeters, that is 60 mm, and 5 to 7 cartridges depending upon the size of the stomach. Minimum 5, maximum 7 cartridge is required depending upon the size of the stomach. But as we can see here, little bit tissue is still left, and if it is this is the case, you should not hesitate to fire the another cartridge. Now the blade is getting pulled, and one more cartridge we have to fire. So both the tip of the stapler should be visible, and you can see there is a small dog ear which is visible, and it is 1 centimeter away from the gastroesophageal junction. So this is done. Now you will hold the pylorus and ask the assistant to put 50 ml methylene blue, or you can do endoscopy to check any leak. Leak test should be done, and we can see the stomach is distending and there is no blue color visible. So this is fine. You have to make it sure that there is no leak. And then you can hold the stomach and you can pull it out from the stapler port. Because that port is 12 mm, so that will be easy to pull out. And then you have to little bit stretch the rectus sheath, and then you will do up, down, right, left. Slowly it will come out. Alternatively, you can use the endo bag to put in the bag, and then you can bring it out. So this is little bit stretching, and then you can remove the artery forceps. Stretching has the advantage that it will be easy to remove. And then this is out. As this port closure is must, you should must do the port closure. Here we are using various needle for the port closure. So this is a various needle or cobbler's. This is cobbler's needle, and you must close the port nicely because hernia chances are more. So this way sleeve gastrectomy can be performed. It's just a simple surgery. So this is the single fire stapler.
There is a better and more consistent way to perform sleeve gastrectomy. We call it the standard sleeve.
This is single fire stapler, and this has an advantage that you can fire entire
An anatomy-based approach using a purpose-built Titan SGS stapler. Insert the standard Bariatric's conical shape angularis protecting sizing bougie, or any sizing bougie, to serve as the guide for placing the Titan SGS stapler precisely in alignment with the key anatomical landmarks. Insert the Titan SGS stapler into the abdomen. Clamping as you go, manipulate the entire stomach through the stapler, from the fundus to the pylorus region. Respecting the key anatomical landmarks and the sizing bougie, the resulting cut line should be approximately 1 centimeter from the GE junction, 3 centimeters from the incisura angularis, and approximately 4 to 6 centimeters from the pylorus. From the top to the bottom, visualize the full cut line in a single plane. Fire the stapler. The Titan SGS continuously staples the entire length of the intended cut line with a single cartridge, delivering 6 staggered rows of staples in gastric tissue in less than 1 minute. Titan SGS provides confidence that an optimal, secure staple line is forming in gastric tissue, with localized tissue compression zones and larger anvil staple pockets. Titan SGS minimizes the chance of misaligned or malformed staples impacting surgical results. Titan SGS provides innovative longitudinal graduated staple technology. Each successive staple is taller, matching the entire length of the staple line more closely with the actual thickness of the patient's native anatomy. After firing the Titan SGS, the resected stomach falls away and the new stomach rebounds, revealing a more symmetrical and reproducible sleeve pouch anatomy. The curved staple line is a continuous staple line, free from zigzags, overlapping, or poorly formed staples. The Titan SGS enables the surgeon to plan for a more repeatable and reproducible procedure that delivers consistent sleeve pouch anatomy every time.
So this is just a product video I have shown you. Now I will show you the real surgery. And this single fire stapler has an advantage that you can use it very nicely, and within few minutes you can perform the sleeve gastrectomy. So we will see the surgery. Here the gastric calibration tube is put, and this is the Nathanson liver retractor. This patient has a small hiatus hernia. You can see a small bulge is there on the hiatus region. So we will start the procedure. So this is the diagnostic. Everything looks fine. This area has a small hiatus hernia. So it was examined. This is a small amount of the fat that is called Belsay fat, that is at the level of the junction sometime found. And that, if you want, you can take out. So this is the bougie. Assistant is holding, and then you can start pulling the bougie little out, and you can start taking all the short gastrics. Once this window is formed, after that it is quite easy. On the left upper corner, you can see that is the The gallbladder is visible, and now it is reached from the pylorus, and now again you will go towards the left crus. So I will take it little faster because I have given less time. So this is slowly, 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 slowly you have reached up to the crus, and after that you will mobilize this area, and here you little bit mobilization, posterior mobilization and lateral mobilization of the esophagus has to be performed because there is a small hiatus hernia. And this is the posterior mobilization, and both the crus should be visible. Then you can repair it. Take care that you should not go very deep on the right side, otherwise you can prick the vena cava, so the left hand should be protected. That's all. So this crural approximation has to be done. Little reinforcement of the this side with the esophagus you can do, but only muscle. If your suture is small, you can clip it so that you don't have to tie a knot. After that, this is the time to bring the single fire stapler, and you can insert it. This is the marking here. You can give a marking to remember, and then check the posterior wall for any adhesion, and this is single fire stapler. You will open it. Here also bougie has to be used, and then you can pull the entire stomach all the way from the fundus to the antrum part all together in one go, taking care that it should be not a cork screw appearance. It should be posterior and anterior wall should be equally taken. And we can see this bougie is there. Again, same way, key anatomical landmarks should be respected. That is 1 centimeter from the GE junction, 3 centimeter from the insusura angularis, and 6 centimeter from the pylorus. And then you will lock it. Once it is locked, after that again you will wait for couple of minutes. So that pre-firing you have to wait and then fire. It has a power stapler, so itself it will do and surgery is finished. So less than 1 minute you can do the entire stapling, and then stomach will be taken out. So this is also a very good technique. Here also you will do leak test, and we can see it has a very uniform staple line, no cork through experience. You can do the flat tire test also, and you can check for any bleeding, check for any, and then methylene blue test or endoscopy also if you want, you can do that. So we can see there is no any bubble coming out, and it is distending with the air, and there is no any bubble. And then you will pull the stomach out. Many surgeons, they do over sewing also on the staple line. But nowadays stapler technology is very advanced. So if you don't want to leak, sometime you can use the shim guard. Shim guard you can use, or other type of reinforcement materials are there that you can use. But most of the time it is not necessary, because it can, staples are very good, and there are few literature which says that it doesn't prevent any of this, and it is not necessary. So now you will hold the stomach and pull it out. So this is a single fire stapler which we have seen. So now I will like to ask if there is any question, then we can discuss the question.
Yeah, is there any? Yeah, you have to come up there. Yeah, sure. I was gonna ask what you draw the comfort time. What is the recovery time after using the lineal straight stapler? You know the after the patient what? Drinking. Normally at 4 hours. And normally 4 hours after they wake up from the surgery, we start with eyes of crushed, and they keep on drinking ice or tasting it. But yeah, for hours they have to start, and they start moving and everything. And for this one, it should be the same with if it's with 4 or 5 staplers or one single fire is the same. But yeah. ¿Alguna pregunta en español? Is there any other question regarding the sleeve gastrectomy? I think there are no more questions for.
Thank you very much. Have a nice day. Thank you.
Thank you, sir.
Thank you.